Hello and welcome everyone to the Understanding Local Data webinar. I'm Zara Gross and I'm the Early Diagnosis Lead in South East London Cancer Alliance, and I'm joined by a panel of speakers. So I'm just going to run through them. So we're joined by Sue McNulty and Adama Jatta, who are from CRUK. We're also joined by Graham Roberts, who is our Head of Informatics at South East London Cancer Alliance, and Dr. Anthony Cunliffe, who is our Joint Clinical Chair in South East London Cancer Alliance, and also the Joint National Lead Macmillan GP Advisor and our GP Advisor for Macmillan in London. So next slide. Thank you. So I'm just going to quickly go over some housekeeping rules. So just to let you know, all of your videos are off and your microphones are turned off as well. If you have any questions, then please use the Q&A box at the bottom of your screens. What we'll try and do is answer all questions during the webinar, but if we run out of time, we'll take them offline and then circulate them through a Q&A. We are also recording this presentation, and the webinar will be uploaded to the South East London Cancer Alliance YouTube channel, and we'll circulate the link to that following the webinar. And also just to ask that all attendees complete our evaluation form. It's an online evaluation form. It will take a couple of minutes to complete, and on completion of that, you'll receive the certificate of attendance. So Sue and Adama, I'm going to hand over to you now to start our presentation. Thank you.
Thanks, Sarah, and welcome everybody. So I am probably known to some of you. I've been working in South East London for 5 years. I head up now the South and North West London team of facilitators. We are facilitators, we're not researchers. But what we're going to share with you today is how to use data for the purposes of the DES, and our experience of going into GP practices and talking about data for quite a few years now in South East London. So one of the first things we're going to cover is about approaching data. We're going to talk about data and DES, bearing in mind that we are at the point of the calendar where we're just getting started with the DES. So this isn't getting into the QI of analysing your data, measuring an intervention and what the outcome is, etc. This is about getting you started on making those quality improvement decisions and giving you, some insight into where you're looking to focus your efforts for the early diagnosis DES is the right place to be looking. We're going to hand over to Graham, who's on the call today from the Alliance, who's going to talk about what data is available from an Alliance level. The National Cancer Diagnosis Audit reports, if you were a practice that took part in that, hot off the press, they've just come out this week. So you can go onto the portal and you can download your practice report. The PCM reports are being uploaded as I speak. So I think they will be available early next week, but at this moment in time, they're not actually out yet, the PCN and NCDA reports. And then finally, we're going to talk about practice and PCN data. If you are interested, or I'm sure you are, in the quality improvement side and how to engage with data for that purpose, sort of taking it on to the next level, I'd highly recommend the RCGP quality improvement site. And I believe that we're going to circulate some web links after this, and that will be included on that. So that is when you get to the next stage of actually doing your quality improvement. The facilitators in South East London are in place definitely until the end of March next year, and we will be putting up contact details at the end of the call. So do use us, do get in touch with us if you've got data questions, if there's particular things that you're looking for, because sometimes it could just be helpful to have a heads up early on that know that data isn't available. So please do get in touch with us. So as I say, I've been a facilitator and managing a team for 5 years. And these are some of the common things that GPs will often say to us when we go into practices and share their fingertips data. And the answers to these overlap somewhat. So the first is data is not recent. Most of the data that we're going to talk about today is up until April 2019 on the fingertips site. The NCDA was looking at all cancers diagnosed in 2018. I think, yes, it is frustrating that data isn't more recent, but it does take time to upload data, cleanse it, etc. And certainly when we bring facilitators into the programme, our advice from our data analysts is data doesn't have to be perfect. Data has to give you some insight into whether what you're doing is the right thing. I guess if you were looking to, commission a very expensive piece of machinery for a big hospital, then yes, you would spend, great more deal of time cleansing that data and looking at it. But the other thing as well is the data, if you're approaching the DES and you're thinking, well, how do we do that? There are no actual KPIs for the DES this year. This is about getting you going as quality improvement clinicians. So it's about, the DES will be process driven. So you're not going to be expected to look at your fingertips data, say on screening this year, and then compare and contrast, for 6 months later, because the data won't be there. But you will be expected to demonstrate that you have, taken steps to pull that together as a process within your PCM. As I say, we've probably already answered that the data is not correct. Really what you're looking for with data as in terms of quality improvement work is that trend and that overview of where you sit with similar practices, with similar patient demographics. And the other point that we get asked by GPs is, they're looking at data and the conversation is flowing and, they come up with the question, well, are we good or bad then? And really with data, what you're doing is you're looking to layer it up, to build up the bigger picture. And, those answers will often be within the practice itself. Data is data, it's not information, it's not conclusive, but it's a great way of getting, clinical improvement discussions going, also deciding where you might want to focus your effort next on drawing down some of that data yourselves. So for example, if you were looking to do something with ethnic minority patients and you pulled off your data and it showed that, in your practice you only had say 2% or something, that might not be, the biggest cohort of patients to perhaps be looking at. You might want to think about perhaps looking more at deprivation, etc. So, data is about giving that overview, that trend, that picture, and giving you some sense of where to look next in your own quality improvement. So as we know, the long-term plan wants to see more cancers diagnosed at an early stage. And this is the data that we have. This is quite old data. This is 2012-13, but this is looking at the stage of diagnosis and the place of diagnosis. And as you can see, national screening programs are 6%, and we have, more cancers diagnosed in the early stage there. That is the value of the national screening programs. But as you can see, the majority of cancers are diagnosed through the GP practice, the GP deciding whether to refer on a 2-week wait or make a routine referral. And as you can see, the difference is the area of real focus is the emergency presentations, because cancers there are much more likely to be at an advanced stage when the prognosis is less positive. So that's just to give you an idea of what the data can tell us about the place of presentation and the stage. This is another piece of data from the previous National Cancer Diagnosis Audit. So again, we're building up the picture there. We're looking to see if that picture tallies with this. And what the National Cancer Diagnosis Audit was, again, seemed to correlate with that previous slide. 67.5 were within a GP practice were diagnosed. The difference is in the A&E, and if you took part in the NCDA, what you will recall is for the A&E attendance, it was a bigger breakdown. So rather than just the kind of the one sort of catch-all of patients diagnosed in an A&E setting, you were asked to recall whether the patient was diagnosed, had been to the practice, was, you know, diagnosed through another means of going to A&E, etc. So just in terms of where data relates to the DES, so the first part of the early diagnosis DES is improving referrals, and with a focus on safety netting. The second is improving local uptake of the national screening programmes. And the third is the quality improvement of those through doing your peer-to-peer discussion. And my experience is, you know, we quite often don't need to do the narrative about data. GPs will do that for themselves by looking at it and analysing. If that sounds familiar to you as a GP and you've been reading the QOF, then it is, because the QOF also talks about improving screening uptake and improving referral processes, and meeting with your peers to discuss what you're going to be doing. The focus of QOF recently has focused on the restoration of those screening and referral rates. I think we're thankful that we have the data pre-COVID to give us that insight into the numbers that we need to be striving for, not only to pre-COVID levels, but also to, you know, pre-COVID plus, to really try and clear the backlog. So in terms of looking at your referral data, we're going to talk about the Public Health England fingertips. Do remember as well, Public Health England fingertips is not just for cancer data. If you have an interest in asthma, you could look at your patient populations as well. So, you know, it really is a great resource in terms of giving that individual practice data for many more, you know, diseases. If your practice has taken part in the National Cancer Diagnosis Audit, you've already got a head start. And if your PCN has taken part in the National Cancer Diagnosis Audit, even better. If you're in a PCN and some practices have taken part in the NCDA and some haven't, the QOF requires a minimum of 20 patients to be audited. And in the handout that we're going to give after today's presentation, we've got a couple of spreadsheets that will correlate with the National Cancer Diagnosis Audit. You're not going to get a 40-page report as you would have done if you'd taken part in the NCDA, but it's a good way of, you know, being able to allow practices within the PCN to have that discussion and to be looking at the same things. So just a bit about the National Cancer Diagnosis Audit. We are really proud, and a big thank you to those of you who did participate. We've got over 114, we had 114 practices take part, and we've now got a really rich data source of 3,300 cases in the data bank to look at and draw on in future years. So, you know, a big thank you. I know, you know, I think the estimated time is 20 minutes per case. I'm sure some cases would have taken longer than that. So it is really appreciated. And if these are the PCNs that are going to have a PCN report, as I said, those will be coming out. They should be out by this time next week. So do look out for those and do use those to inform your discussions at this stage. Just these are from the interim reports that came out in January and June. If you logged on and downloaded one of those, I don't think there were any available for PCNs in this patch, but certainly some were available available for practices. So just to give you a bit of a taster of what's in the NCDA, it gives you a breakdown of the cancer types. And if you look at the colour code, you not only have it for your practice and the Alliance in England, what the audit has also done is measured your practice and given a yellow bar, which is looking at similar practices with a similar patient demographic in the country. What's really, what the real added value of the NCDA as well is that it gives you in the report the breakdown of your cancer stage. So for this particular practice, they had 44.4% of cancers diagnosed, and that at the time was compared to 45.6%. So again, just giving you a taste of what will be in those. The place of presentation, unsurprisingly, is the GP surgery. Probably if we did that, repeated this during COVID, we'd probably see a much bigger telephone consultation, etc., or face-to-face virtual calls come up in that. So just before I go any further, are there any questions about the NCDA or what I've talked about so far?
No questions at the moment, Sue.
Thanks. Okay. We're going to talk about Public Health England fingertips data. As I say, Public Health England fingertips, it's benchmarks, you can benchmark it in different ways. So you can look at how you compare against England, the CCG, the PCM. It does give the demographics. Hot off the press, I'll show you in a moment. If you go to the fingertips site on Tuesday, they updated it and they very helpfully have put the key indicators for DES on the landing page. So that will make it much more easier to navigate for you. It does give the number of emergency presentations as well. You will need to be wary of some data limitations. Some of it is very, very small quantities of data. So again, you know, you need to be mindful of that when looking. There are also 2-week wait referrals, what we call the conversion rate. So that is the number of cancer referrals and the number of cases of cancer that have been diagnosed from that cohort of referrals. The other way that you can look at it with a different prism is looking at the detection rate. So you can either look at, the other way you can look at it is you could say, well, okay, we had 20 cancers diagnosed in this practice in the last year. What proportion of those were diagnosed through the 2-week wait setting? So the detection rate is the percentage of new cancers diagnosed via a 2-week wait route. So this is the website to go to. There's two. You can either, if you're looking for, you know, if you want to look at a sort of selection of clinical areas, you can go to the generic fingertips.phe.org.uk, and then on the right is the Cancer Services specific website. And you just press start. You don't need a login or anything. You go in there. And as I say, this week we've got a different landing page because we've got the summary of key indicators, which, as I say, are the key ones for the DES. What is really helpful on the, or what's important on the fingertips is really setting up your dashboard. So as you can see here, there's a selection, there's a drop-down menu of the area type, the areas that are grouped by, and I guess everyone on this call today would be looking for that to be at a PCN level, and also the benchmark that you can choose as well. Probably the most common tabs here that I use are the trends and the compare areas. And what's really helpful as well is the definitions. So if you're looking at a particular indicator and you're thinking, you know, that doesn't make sense to me, what is the data that we're talking about? You can click on the definitions button and it will give you very helpful breakdown of what it, you know, where the statistics have come from, what the time frame is, etc. So as I say, you know, setting up your dashboard is going to be, you know, really get you started with looking at your data. One of our colleagues in East of England has done a really helpful video because it's a bit difficult to show you through screenshots. So if you're going on there and you want to learn, want to find out how to navigate it, do take a look at that YouTube video. The link is there, and that will help you get going with it. So the data that I'm going to share with you now is looking at trends. It's looking at a particular practice in a PCN, and it's looking, the reason we have to do that is that's the way you have to do it to get to see all practices within the PCN. And as I say, here is the indicator button over here, and there are all different kinds of indicators. The important thing as well to point out is there are 2 tabs. So sometimes I think it used to land on this one, but you will get a whole different data set if you click on this tab here as well, which will be all about your 2-week wait referrals. So we've blanked out the GP practice. For the record, the practice that we're going to show is not a London practice, in case you're wondering if it's your PCN or practice that we're sharing. And we're going into it, we've picked the GP, the PCN, and we're looking at trends. So the first thing that we can see on this is we've got the practice, we've got a helpful code up here, which is very, very basic. It's showing it against the benchmark, whether the practice is lower, similar or higher. This indicator is 2-week wait referrals. So it's the number of 2-week wait referrals that have been made. And as we can see, the benchmark is against the PCN. So that is the black line. And the practice has been steadily increasing its 2-week wait referrals. So that's quite interesting. Where it gets a bit more interesting is if we change it to the compare areas, and then we can see all of the practices then within the PCN. So as we can see, there's quite a bit of variation. We've got some who are higher than England, one that's similar, and a few that are lower. And again, going back, sticking with the 2-week waits, if we look at the conversion rate for that same practice, we can see that in both the PCN and the GP practice, the conversion rate has started to come down. That is the expectation as GPs have started to refer more, with the introduction of NG12, the number of referrals has gone up. And the conversion rate across England has started to come down. And over here on this chart, you can see as well, that's the England conversion rate. We've got the GP practice as well. And then over here, we've got the PCN's conversion rate also. As I say, the other way that you can look at what's happening with your 2-week wait referrals is to look at the detection rate. So you can start to look at the number of cases that were diagnosed through a 2-week wait referral. In this particular example, it's a much less linear line. It's jumping around here. Again, we would take care with that because, it's a very small amount of cancers that we're talking about. But it's about, getting the discussion going. And as I said at the beginning, it's also about giving you that insight. So if we did say, right, we want to do an audit, we want to find out, how many, for example, if you were thinking about taking part in the next National Cancer Diagnosis audit, this would tell you, okay, for that practice, you would be looking at auditing about 20 cases. So I'm going to hand over now to Graham, who's going to talk about the Alliance data.
Thanks, Sue. So for those of you who don't know me, I'm Graham Roberts and I'm Informatics and Data Lead for the South East London Cancer Alliance. I'm just going to run through a few slides with you today, just looking at some of the data sources and associated analysis that we use regularly to support our Alliance priorities. The next slide. So the first slide I'm going to show you looks at screening coverage for South East London in 2018-19, which is split into the 3 screening programmes and by the South East London boroughs. So this is data that we've actually have downloaded from fingertips and processed ourselves into the visualisations on the slide. And the data is, of course, programme collated data that comes from Open Exeter. So the charts show screening coverage percentages across the 6 South East London boroughs, which is the blue bars, South East London combined, which is the black bar, and the London region, which is the grey bar. And the red dotted line is the national target, which of course for breast and cervical is 80% and bowel 60%. And the green line is the England average. there's lots of scope using this data for comparison and trend. And you can see from the charts that the greatest variation between boroughs that we have in South East London is probably in Bowell, which is the top right-hand corner slide chart. Next slide. So the next two slides look at early stage diagnosis of cancer, which support the 2028 target of 75% of cancer being diagnosed at early stage, which Sue mentioned earlier. The data that supports this priority comes from the online tool cancer data, which is fed by the National Cancer Registration Service data. And it ranges from, going back quite a long way actually, from 2001 to 2018. Allows us to look across 21 individual cancer types with splits for things like deprivation and different geographical breakdowns. And importantly, actually, this data is also case mix adjusted, and that's by things like sex, age, diagnosis, deprivation and cancer site. So that allows a lot of different geographical comparison that you can do. So on this slide, you can see that for the 6 South East London CCGs, the trend of case mix adjusted cancer diagnosis at stage 1 and 2 over the 6-year period, 2013 to 2018. And you can see the greatest improvements over the last 6 years have been in Bromley, which is the orange line, followed by Southwark, which is the green line. And there's been quite linear trend in Lewisham, which is dark blue, and Greenwich, which is grey, both the lowest CCGs at the minute, which are just below 54%. Next slide. Thanks. And just continuing on from that, this chart shows a breakdown across the 21 cancer types available of early stage percentage of diagnosis, which is the blue bar, versus late stage, which is the orange bar for South East London in 2018. So just picking out a couple of the larger volume tumours, you can see that breast above the target at 81.2%, whereas colon and lung are both below 50%. The next kind of stage of analysis with this kind of thing would be actually looking for that comparison. So what we'd normally do is compare ourselves to the London region and to national as well, to give a little bit of context to South East London performance, to see whether or not the percentages that you're seeing on screen are actually good or bad, and that would obviously inform any local improvement work we want to do, particular tumour groups. Next slide. So the final one for me looks at sort of our South East London use of local data sources, particularly in response to the pandemic. So over the years in my role, I've developed data feeds from trust cancer systems and other trust systems such as imaging, endoscopy, PAS systems to support our ongoing alliance priorities and allow for a real-time analysis on particular areas. Some of the current focuses obviously are on the recovery of things like the 2-week wait referral rates and treatment rates, along with reducing 6-day backlogs that have been impacted by pathway delays due to COVID. The chart you can see in front of you shows a week-on-week comparison of GP 2-week wait referrals that have been seen at South East London Trust, with the orange bar being 2019 and the blue bar being 2020. And this ranges from the first week in March up until weekend in the 27th of September. So what you can see is that obvious reduction in new 2-week wait referrals that were seen at the start of the pandemic, with a gradual recovery during and post-lockdown. And since the August bank holiday, we've seen quite a close correlation with pre-pandemic levels over the last 3 or 4 weeks, which is positive, obviously, in the current climate. And that's it from me.
Thanks, Graham. Okay, are there any questions so far?
No questions yet,
None
Sue.
at the moment.
Okay. All right, so I'm going to hand over to my colleague Adama.
Thank you very much, Sue. So hi everyone, so I'm Adama, and like mentioned earlier on, I sit within the Facilitator team that works for South East London, and I work for the boroughs of Bexley, Greenwich and Lewisham, and I'll be taking you through looking at your screening data, specifically using Public Health England fingertips. Okay, so just to take it back to the PCN DES specifications, the second element of that is making sure that PCNs and practices are contributing to improving the local uptake of national screening programs, and doing this by working with local system partners. And what's required? So what's required is, again, working with local system partners such as ourselves, but also agreeing on your PCN contribution to improving the uptake and coverage, and making sure that you are developing an action plan to implement this. Most importantly, though, is building on any existing actions across practices, but really looking at your particular patient groups that have been historically difficult to engage with or more challenging to engage with. So making sure that at least one of the action plans is to look at how you can engage with these low participation groups. So how can we do this? So one way of looking at this is looking at your Public Health England fingertips data, which I will take you through in a minute, but also identifying particular groups of patients where you might find that they have been low engagement. And in order to do this, I mean, the purpose of doing this is to make sure that we are reducing the level of inequalities, you know, for these patient groups. So such groups will include men. We know that men are sort of harder to engage with compared to their female counterparts. Patients from ethnic minority communities, and this is due to cultural barriers or language barriers. So linking in with that, patients where English isn't their first language. Patients with disabilities, both physical and learning disabilities, and your LGBT patients. I'm just going to put this on. So what you can do as well is CRUK do have a guide named Reducing Inequalities in Bowel Cancer Screening Guide. And within this guide, it's got some top tips of how you can engage with these patient groups. Yeah. So one thing that you can do as a good starting point to engage with these groups is looking at your patient demographic within your practices as well as within your PCNs. Now, obviously, GPs and GP surgeries are probably, you know, the best placed individuals. They really know, you do really know who your patients are. But just pulling up this information on Public Health England fingertips really supports you in just giving you an overview. So what you can do is, if you go into Public Health England fingertips and you go to the bar at the top, you've got these different tabs and you select the population tab. This is the page that will be pulled out for you. So if we look at the left here, you've got the age profile for your particular practice, and it compares it to your PCN, and so that's in the pink line here, and it compares it also to the England average. Now you can change this, so if you wanted, you could filter this and change that to CCG, which will take out the PCN, and you can just compare it to the England average. So what it tells you here, the dark blue charts, bars, on the left is your male population, and the light blue bars are your female population. And here on the y-axis here, you've got the age range, so age 0 to 95 plus. So if we look at this a little bit more in detail, what you can see is that for this particular practice, most of their population seems to sit within the male demographic, and also fairly young population between the ages of 25 to say 55, and also a fairly young female population, specifically around the age group of 25 to 35. And compared to the England average, they have a very, very low elderly population, but it is very much in line with the PCN average. So you can see that there. And what you can see here on the right, which is quite useful information, is the ethnicity estimate. So for this particular practice, 39% of its population are Black, 8.1% are Asian, 6.4% mixed, and 4.2% are other non-white ethnic groups. So what this might indicate is that potentially a lot of the patients within this practice might have language barriers there or cultural barriers there. So you might want to think about how can we really engage with these particular patient groups? Would we want to implement resources that are translated, or make sure that we've got interpreters within our practices to really support with that? Like Sue mentioned earlier on, by getting a really good picture of who your patients are, you can really start to think about your quality improvement projects and what you can implement. And here you've got the deprivation score there as well, so you can really sort of start having, think about the challenges that your patient groups might be living with or presenting with. So let's look at how you can find your screening data. So Public Health England Fingertips does give you bowel screening data, breast screening, as well as cervical screening. And you can pull out your bowel screening coverage data. So again, it gives you the information for your particular practice, and you can compare it to your PCN, but you can change that filter if you wanted and compare it against your CCG. And I've pulled out here the trend, but you can do, you can pull out more information on that, which I'll show you in a minute. So here you've got persons aged 60 to 74 screened for bowel cancer in the last 30 months. And, it's really useful when looking at data, like Sue mentioned again earlier on, is by looking at the trend. So you can see here, whether is this the sort of trend that you want to be looking for, what you want to be looking towards, and you can compare it to your PCN. So the black line here is your PCN data, and the light blue line here is the practice trend. And here again on the right, you've got the values, and you can see over time, these values are going up. And again, you can compare it to the PCN values, and again, compared to the England values. And you can do the same thing again for your bowel screening uptake. So the people, persons aged 60 to 74 that have been screened for bowel cancer within 6 months of an invitation. And again, so you can see, are we going in the right direction, and how are we in comparison to the PCN? So like I said, you can, so I showed you just now what the trend is, but you can do, you can sort of compare yourself amongst other practices within the same PCN. So here you've got the England average for uptake, you've got the PCN average, and you've got all the different surgeries within that same PCN. You can find where you are within this, where you're placed on this graph, and you can really see how you're doing in comparison. And what this shows is that there's quite a large variance here in this particular PCN, and this could be for lots of different reasons, but having that conversation as a PCN would be really useful, looking at what are the processes, is there a particular reason why one practice has got a particular figure over another practice, and maybe thinking about implementing a standardized approach as a PCN should hopefully help you level out this sort of graph and how it looks like. You can do the same for cervical screening. So again, this shows you the trend, and this is really useful because you can see here, unless a practice pulls out this sort of data, they might not realize that actually their trend is gradually going down. They might do, but they might not realize. So just pulling out this information can be quite useful. And again, you are comparing it to your PCN. So that is Public Health England Fingertips data, but you can also get cervical screening specific data using this dashboard here that's been put together by Joe's Trust, NHS Digital, and Public Health England. And I've got the link here, but again, Zara will send out a link to everyone at the end of this session. You can go into this dashboard, and it gives you much more up-to-date information on the data of your practice in comparison to your CCG. So I'll just take you through it very quickly for those of you that might not have seen it before. This is what it would look like. And what's quite useful about this data tool is you can separate out the data according to the different age groups. So you've got the 25 to 49, you've got the 50 to 64. You can select which one you want to look at specifically. I do know this might be quite useful because with the changes in the QOF as well, I believe you can get more points if you're specifically targeting the 25 to 49 age group. So this might be quite useful for individuals to look at. And you can also specifically select the different boroughs. So this is done by different boroughs. So you can select Bexley, Greenwich, Lewisham, or Lambeth, whichever one it is. It does do it according to the different boroughs. And here at the bottom here, I have blocked it out for confidentiality, but you can select your practice here. And again, you can select the date range that you want to look at. So again, what it shows here is the practice coverage. And you can see it's a little bit higher than the CCG coverage. which is a little bit less with the 80% target, but you know, it's very much that this particular practice are doing really well with meeting that 80% target. And just to say, unfortunately, the data here is only, it is at a CCG level, not at a PCN level yet, at least. And what you can see here, which I think, you know, people might find quite useful, is it shows you the data in comparison with how many individuals within your practice are eligible versus how many that particular practice is actually screened for. So you can see, you know, maybe what the difference is there. And again, if you have to keep selecting it every time you go into a new page, but what you can see here is it gives you the exact figures of how many patients in that practice need to be screened in order for that particular practice to reach their 80% target. So here, if we look, for example, you've got 2019, 2020, Q4, and again, it separates it out between the two different age groups, 25 to 49, 50 to 64. You can see that only 28 patients within that age group of 50 to 64 need to be screened in order for this practice to reach their 80% target. So you can really focus, if you decide that you want to you know, undertake a quality improvement project on cervical screening, you can really look at this data and it can really support you, and it can also really help you focus on how you want to, you know, for example, I'm going to screen, our particular practice are going to screen five individuals within this age range every month, or however you want to do it. So it gives you that idea, it gives you that picture. That takes me to the end of the screening presentation, and just as a quick reminder that there is an evaluation, so please do or fill out the evaluation when you can. And now it takes us to any questions. Does anyone have any questions?
Thank you, Adama. That was great. Does anyone have any questions, or do our panelists want to add anything more? No? Oh, Anthony, you're on mute.
There we go. No, not really to add anything more, just to thank Sue and Adama there, really. I think a lot of the time as primary care teams, we can sometimes start our QI work with really great intentions, but start kind of halfway down the pathway and forget about really looking at the data and the importance of understanding our data, so that we can really target the time and effort that we put into our quality improvement work. So it's really great to have a session on how we can, you know, find that data, and mainly how we can understand that data as well, because a lot of us might feel that we don't have the time to look at a spreadsheet like that when we don't know where to start. So you know, having it kind of explained is really useful. And I would really encourage, you know, primary care networks to have, you know, spend a bit of time. You know, it's really important to thinking about the resource you're going to put into your quality improvement work. You know, it's really important to factor in that time to really understand the data, so that you can do what's most important for your primary care network, most important for the demographics in your primary care network, so that the outcomes, which is what quality improvement work is all about, so the outcomes really have an impact. So yeah, thanks for that.
Thank you. So just to remind everyone, I'll be sending around the evaluation link. I'll also be sending around, oh no, that's not a question. Thank you, Alison. And I'll also be sending around a document with all of the links that have been mentioned here and any support documentation that you might find useful. So we are 15 minutes ahead of schedule, which is great. You can go and all have some lunch. So I'd just like to thank our panelists. Thank you, Adama. Thank you, Sue. Thank you, Graham. And Anthony, thank you for joining too. And also thank you, Bav at Guy's Cancer Academy. So take care and see you at the next one. Bye.